May we thank everyone who have joined today's session. And we appreciate that you are all here. My name is Sandile Maslam, and I'm hoping others will join us as we continue with the session. Others are saying they're still trying to join us, so because of time, they will find us continuing. With me here, I'm having my team from the Eswatini Hospice at home. I would like at this moment to allow everyone to introduce him or herself. When you introduce yourself, you kindly mention your name and the place where you are coming from. And then after you have verbally introduced yourself, we kindly request that you introduce yourself on chat box by writing your name and the place you are coming from in your profession. Possible even an email or contact if you have, we can appreciate that. So if you have people joining with you, we will request that you also allow them to introduce themselves so they be able to tell if we are all audible enough for the day. So may I start with Lumile Masubu. May you introduce yourself. Lumile, do you hear us? Okay. Lumile. Okay. May we request Nana to introduce yourself while we are still waiting for Lumile to respond.
Good afternoon, team. It's Nana Sandu here at Mazuni Government Hospital, from the in-service department, and we also have Portia Lamini from the in-service department at Mazuni Government Hospital.
Thank you, Nana.
Still waiting for the others
to join. Okay, we hope they will join and find us on the way. May I kindly request Nana that you would introduce your team members also on chat. Lumile, are you there?
Yes, I'm here. Can you hear me?
Yes. May you introduce yourself and others if you are joining with them?
Okay, sorry, I'm alone. Sorry for the delay. I am Lungle Masugu from Manzini Government Hospital, from the in-service department. I am alone. Some are busy in other wards.
Okay. Thank you so much, Lumile. If possible, you will also introduce your name by writing on chat and where you are coming from. And then we have Nancy Gelelo. May I give you this opportunity to introduce yourself? Unmute yourself. Yes.
Afternoon, colleagues. My name is Nonsigele Lontuli from RFM Palliative Care.
Thank you so much, Julie. May I request Mike Gamente to introduce yourself?
Good afternoon, team. I'm Zoda Gamente, working for Eswatini Hospice at home. Thank you.
Okay. May I give this opportunity for the team that is with me to introduce themselves? I will start with the one by the door, so they will introduce themselves. So may I start with Smomile?
Good afternoon, team. My name is Morris Melani, working for Hospice at home, one of the team members here. Thank you.
Yes, Duduzo.
Good afternoon, team. I am Nondudu Zotani, also a member of Hospice at Home.
Yes, our mistake. Me.
Afternoon, team. My name is Brendan Chamini. I'm also a member of Hospice at Home.
Yes, our Shiseleni is.
Good afternoon, team. My name is Pennington Lamini. I'm working for Hospice at Home under the Shiseleni region.
Yes, thank you so much. Next to me, I have Manzini Nance.
Afternoon, colleagues. I'm Samuel Bukele, also a member for Hospice, so Eswatini Hospice at Home.
Yes, I will ask if Simran, do you want to introduce yourself? Okay. Today's session, may I encourage you to continue then to introduce yourself on chat. So you write your name so we can capture your details. And then may I introduce that today our session is all about pain. So we are starting a new series. We have covered the past two series on ethics in palliative care, where we were looking at the ethics, the four main ethics, and then we look at decision making in palliative care, and we also look at ethical problem solving. We also look at the communication series, where we were looking at core elements of a clinician communication and then family meeting skills, and then we look at how to break the bad news, and then we look at how to go about advanced care planning and goals of care discussion with patients. We also looked at the issue of code status discussion, and when we're looking at medication that we may or patient may or may not need at times of end of life, and then we also looked at communication during the transition of care. So now that we've covered these two components of things, we were preparing for this broader theme, which is pain, which is most of the time the centerpiece of our existence and the purpose of our activity. So now we will be starting another series that will run almost the next 4 or 5 years. But in the next 14 weeks will be 14 sessions that are coming. We will be looking, or 14 months. We will be looking at pain. So today we will be looking at pain. And then in overview of what happened in our previous session, last session we were talking about the transition to death. And we understood that communication doesn't end with the patient while he's able to talk, but even at the time of death, we continue to talk, and with the communication, being our body language, comfort, and being present itself. So we look at those issues and the importance. And then we had a case from Lubogo region, which was a patient with an advanced stage cancer. Who had 4 admissions, hospital admissions in 30 days, who was in for 4. So the patient was complaining of pain and with an acceptance of end of life or death, yet the family were not prepared. So the patient presented with certain physical symptoms and psychological ones, which were mild depression, anorexia, constipation, anxiety, and dyspnea and xerostomia. So in the management, it was agreed that the nurse should consider a holistic assessment and discussions of end of life. So today, I would request Mr. Mkele to share the screen on our presentation today. So I will be just sharing the introduction of our series today. And then we will have a case presentation from Relief Wilkin Memorial Hospital Palliative Care Unit, which is RFM, to be presented by Nurse Nduli. So this will be just a brief presentation. We'll just go through it, and then we rush to our case presentation for RFM. I will say that these are the sessions that we are learning so much from them. So what we are going to be looking at here will be looking at what is paid. So we will also be looking at the total concept of pain, and then the two classes of pain, implications of chronic pain, and challenges of chronic pain, the classification of pain types, and summary, and then questions. You know, we will not be detailed because this, we understand, it's just a reminder, and it's just a foundation of our next coming series that will be on details. Let us also assure you that we will not be taking the bigger chunks of this information in the next coming series, but we'll be taking bit by bit so that we all share our knowledge and understanding in the management and assessment of pain. So, may I say that pain is a health issue, so that's why we are also have to work on it and alleviate it, and it affects everyone, whether you are a healthcare worker, or you are a client, or you are a family, or you are a manager, or you are so everybody is affected it. The most common and painful symptom expressed by palliative care patient is pain. This is the most, and is the impactful symptom. In all symptoms, pain is the worst symptom that is experienced by our patients. So most of the time, the common one is the moderate to severe pain. And this one is very common to patients who are approaching the end of life. So, and it results to distress to the client and the family. So therefore, we need to look at it and be reminded now and then on how to deal with it. So to deal with this, we need to equip ourselves and to polish our pain assessment and management skills, because these are critical aspects, especially in palliative care. So as healthcare professionals, then we need the frequent reminders concerning this concept. So then the question is, this unpleasant, critical, or impactful symptom, what is it, sir? So it is being defined as an unpleasant sensory emotional experience associated with actual or potential tissue damage. That's the general explanation of it. What I like about this sensorial or emotional experience is that it is always subjective. That's what makes it so complicated. It's subjective sensation, and it's always unpleasant. So the fact that it's subjective, no one can decide to say you have it or not. The experience varies from person to person and from time to time. One patient can present different definitions or explanations concerning what he or she is experiencing, and each and every patient experiences these differently. That leaves us as healthcare workers with the challenge to deal with this ever-changing multidimensional concept. It's whatever the experiencing person is saying it is, and it exists whenever he says it does, regardless of what physical or emotional or mood or affect I'm presented with by the patient. It doesn't matter, but when the patient says she or he has pain, it means there's pain. So that's why we need to understand about it. So this one then draws me to the concept that we'll be dealing with in the coming sessions in pieces and in pieces. In the coming sessions, we'll be looking at physical pain, the concept of total pain. So if we're referring to pain, we talk of the concept of total pain, especially when we're talking to patients with life-limiting or life-threatening conditions. We have physical pain, the pain that we are used to, the ones that we can even sometimes see physiological symptoms that detect as pain, spiritual pain, and cultural, psychological, emotional, and social pain. And all these types of pain, they will result to what we call total pain. Therefore, it means you are not complete with the patient when you will be only attending to the physical pain. Then in our coming next session, for the coming years, we'll be unpacking this total concept of pain, so that we then find a way to join them or have a way to access all of them and manage all of them comprehensively in our different facilities. And then it leads us to describe the two classes of pain, which can be acute pain and chronic pain. That one we know. And what we can agree on as healthcare workers is that this acute pain is normally associated with an injury or an illness, and it's typically recognized and successfully treated this type of pain, the acute one. And it is the most familiar type of pain to us as healthcare professionals. We are more familiar with it. But there is chronic pain, the most problematic type of pain that we face daily. Most problematic to recognize, let alone to understand and successfully manage. It's very problematic to recognize, let alone to understand and successfully manage. It persists beyond the expected period of healing or responding very poor to the treatment. You know, sometimes you'll be giving a patient the morphine of 80 days, and then you expect it to be completed within 30, but the pain will somersault within 7 days. And then the patient will find the patient presenting back to facility. So it's very complicated. And this normally is an effect that persists for 12 weeks, regardless of treatment. So you find that whether any non-pharmacological or pharmacological intervention, it continues. So normally we call the pain as chronic. It's far from invisible to those experiencing it. So it's very difficult to defeat such a pain. But at the same time, very much needed from those who must justify the treatment. So it's very difficult to deal with it. But through this session that we're going to have, we will have time to advocate this type of pain, so that all of us, whether the patient presenting Babani government, or whether the patient presenting Nazarene or Manzini government hospital, we will be able to manage this type of pain. So we'll be helping one another on how we can best deal with this problem of chronic pain. So we can also agree together that there are implications that have come with chronic pain. One of it, the high prevalence of chronic pain results to profound implications for the national healthcare system. So once more people have more pain, the more the health system will have more problems. Two, the high number of clients or the increase in clients with chronic pain in our national system, our national quality of life suffers. So the more people are having psychological pain, the more we suffer. The more emotional, the more spiritual, the more physical, the more the holistic total pain increases, especially the chronic one. Then the more we are going to suffer. Quality of life will go down. National health system, the budget will go up. So we need as healthcare workers to deal with this monster, which is called problematic pain. Treatments are multiple, costly, and never ending. You never say, now I've achieved. Every day there's multiple. You need this and this and this, requiring multidisciplinary approach. They are very costly. Morphine you cannot even buy it on the street, especially in this country. It's very expensive to procure it. So they are very expensive. So, you know, and once there is chronic pain, production, whether it's at work, it goes down. Because the increasing number of people who are able to work because of pain, and this one leads to claiming people to disability, you know. People end up living with mental illnesses because of pain, resulting from life-limiting and life-threatening condition, which then leads to an economic hardship. So we are going to have a challenge in economy because people are not productive at all. And if you find that you discover that this is as a result of what? Chronic pain. And as healthcare workers, we are placed at the door of treating chronic pain. So we need to be able to assess and manage things. Then another implication that comes with this type of pain is that individuals are abandoned to fend for themselves. While the patient is been presenting with chronic pain untreatable like this, then they end up left on their own. They are left like a GPS in the you. Then you are when you ignore the GPS demand or advice, then the GPS will say to you, you are on your own. No matter what happens with our patients. Once they are suffering this type of pain, they are left alone. Some of them, they are there at home abandoned. So they are on their own. That means the health system that is becoming less stable over time. So if we have more people who are abandoned, who are fending for themselves, some will take little things, some will commit suicide. You will find that at the psychiatric hospital, more patients will be growing because most people have been exposed to chronic pain and healthcare workers couldn't be able to manage it. So that's another implication that we need to understand. Why do we need to sit together and deal with this monster, find a way to deal with it? Another thing that we need to understand that there are challenges that comes with that to consider in pain. We have challenges that we will be helping one another to deal with during the session that we will be presenting in the next coming session. One of it is the challenges that we face as healthcare professionals, which is poorly informed attitude. You know, we have different attitudes when it comes to pain. So we will be trying to unpack those cage of attitudes that are limiting us in managing and assessing this type of pain. And then also we have exaggerated concerns about addiction, you know. 1, 2, 3, healthcare worker will say addiction. So you may not blame because of the complicated type of pain that is normally present in our body, which is chronic pain. And then you also understand that we have the challenge of reluctance to treat unless demonstrable pathology is presented using medical diagnostics. You know, people will say, I need to take you to this and this and this so that I can agree with you that you have pain. You know, our pain sometimes they undergo a lot of investigation. We are trying to justify so before we can treat. So that are the limitations we'll see how we can go around all those things as through the conversation. The other systematical issues in the health system is that the limited formularities, you know, sometimes we want as workers to manage the pain, but we will agree that you will find that there are limited formulas to treat the pain. For example, you will find that we need a liquid morphine, but we only have tablet. You know, when a patient is allergic to this or is not reacting very well to this, but sometimes we don't have options to take to another drug. So we'll be looking at all those issues, how to deal with them when times come. Sometimes we'll be poorly designed documentations and forms of checklists that unnecessarily meet the pain assessment. You'll find that when you go through our hospital admissions for OPD files, they are limited such that we aren't able to do the total pain assessment. That means it. So we'll be looking around those issues, how we can come up with improving the documentation or even our checklist so that they can accommodate the total pain assessment in our facilities. We will also look at the issues and the restrictive laws and regulations concerning medication. You know, we know that morphine currently is only prescribed by the doctor. Sometimes other drugs are locked somewhere. Sometimes other drugs cannot be decentralized to the clinics. So we will be looking at how then do I work around such issues if I'm in a clinic where I cannot be given a right to prescribe morphine or dispense. How are we going to deal with that? How best to care? We will be sharing those things to support one another, so that even our colleagues at clinic level will benefit. And then we also have other challenges that we need to consider in pain assessment and management, which include poor communication from the patient side. So after this series, we will be able to help our client to be good communicators, able to report the pain, because sometimes they underreport the pain, maybe related to cultural pain. They will underreport physical pain, you know. So sometimes they underreport the pain. Sometimes they over-report the pain, catastrophize everything. Everything is a disaster. Sometimes you even then prescribe something more than what you are supposed to do, because we have failed to educate our patient how to do it. And then sometimes they poorly describe the pain, then you will find that they are not assisted. So we learn how to help them describe the pain as possible as they can so that they can be held very well by us as healthcare workers. So, and then I'm pushing it to this graph that is there. On the top, I've written chronic or acute pain. So we have three categories that we can put pain into. There's nociceptive, neurotic, and mixed pain. So we know all this, so I will not dwell much in it. So then we have somatic pain and then we have visceral pain. For example, if we talk of somatic, surface somatic nociceptive pain, we talk of sharp and stabbing or pricking. And if we talk of deep pain, normally it presents dull, aching, and localized pain. And normally these types of pain are sourced from bone, joints, muscle, skin, and connective tissues. So we classify them as somatic pain. And such pain is a different type of pain. We'll be unpacking as we continue with this, how best you can deal with this type of pain when it's presented to yourself. Sometimes when you're writing pain, it is easier to just write, oh, you severe pain. And then that one, we find that it also limits anyone who will take care of them. What type of pain was said? If there, you will describe it as dull, deep, somatic pain. And then somebody will understand what you're talking about. Oh, dull, deep, somatic, chronic pain. Somebody will understand what type of pain you're talking about. So with visceral one, the internal organs, and these ones, such as these ones, include the internal organs like gallbladder, liver, intestines, even chest pain is categorized under visceral pain. And it results from distension or compressions and not usually localized. So description and localization is very difficult for such a pain. Even if you will ask the patient, show me where the pain is, you will see the patient moving the head up and down, trying to show where the pain exactly is emanating from. So normally they will present or describe this pain as a pressure or stabbing or cramping, etc. So you will know, oh, this is the type of pain. And we will find other means how best we can work around such pain, whether it's chronic or acute pain. And then we also have the neuropathic, it can be peripheral or central or sympathetic mediated pain. And normally these types of pain are described as burning, tingling, and electrical or needling. So it depends how the patient will describe it. Sometimes it will even be more transferred, this one. So because the pain is being referred from one place to the other. Then we have the mixed one, which sometimes makes it very difficult to work with this patient. Most of specialty patients with advanced diseases, they will have the mixed, both nociceptic and neuropathic pain. So it's very difficult to deal with this pain because it originates from different sides. So, and this one requires the multidisciplinary therapies. So we needed to combine many things. Among disorders that may include is a migraine, chronic daily headache, fibromyalgia, phantom limb pain, multiple sclerosis, skeletal muscle pain, myofascial pain, syndrome, and low back pain. So these type of pain, they are very difficult. Sometimes they are neuropathic and they are nociceptic, so it's very imposed and difficult. When they really become a chronic illness, it's very difficult. Sometimes they require to embark on a multidisciplinary approach or combine different therapies to deal with it. So another thing that we want to introduce to you that will be also take
Mr. Sandile, we cannot hear you if you are speaking something. You're on.
Sorry, do you hear me now?
Yes, we can hear you now.
I was saying that looking at the above issues concerning pain, and especially chronic pain, which normally our patients present with, we can then now agree that comprehensive assessment is the best starting point in dealing with or management of pain. So we'll be looking at it, how best we can do comprehensive assessment, taking it piece by piece, so that we can all understand the areas involved. In the next 14 months, we'll be unpacking the concept of pain from the general specifics, generals to the specifics, from assessment to management. And then we will later then look at the common pain disorders in each in detail, and how then we can best manage it. So no stone will be left unturned in this issue of pain, because it is the cornerstone that we are mostly present, and sometimes we are unable to deal with it very well for our patient. So we request that in the coming session we all join and be part of it, because our next one would be on the pain assessment. So we'll be looking at pain assessment, what is it all about, implications, and the type of assessment, how to do it when you are to do it yourself. I don't know if anyone will have a question or have to do something. And as today we're introducing this concept that we'll be dealing with it daily. I will say that these are the series that will require you to be there every time we have the session, so that you don't miss, because once you miss one step, it might be the loophole that we are taking. I don't know if we have any questions or additions to this concept. If any you may want to add or share. Comments, I see your hand, you may unmute and share your work.
Thank you so much, Sandile, and thank you for the elaborate introduction. I want to add my observation as part of the team, that as we have just said, that this is the very important exercise that we need to undertake, total assessment. And I think of pain. And I've observed that most of the challenges that we have with patients with chronic pain is due to the lack of proper skills on assessment at the initial stage when the patient is starting the journey of palliative care. And then with all the other medications that may give, if the pain was not well assessed and it's not continuously being assessed, we miss meeting the patient's need and promoting the quality of care that we intend to promote. So I also want to encourage us all to be part of this, so that we contribute and we learn in the process. At the end, then we shall have patients who are well controlled of pain, and we shall actually improve their quality of life, which is our goal in palliative care. Thank you so much.
Thank you, Gamet, for such a wonderful insight. Really, this is the issue that we need to deal with it. And I'm hoping the next coming series will not leave a stone unturned in this issue. And we will all be empowered and learn from each other how best we can for our patients. You know, it's at the end of the day, it's for them, it's about them. But we know the implications of the issue that then comes at stage pain that we'll be dealing with. Anyone else who wants to comment on this issue? Before then, I will open for Ziggy to share today's case. You are free to also share on chat your comments, your questions. Feel free to put it on chat. We are going to be able to get it and then share with the audience too. Okay, thank you so much. Today our network is not playing good with us, so should we not get our voice inside, kindly notify us so that we can prepare. So we are sorry so much. May I give this opportunity for you, Nesman Figelelo for RFM, so you may present your case for today. Thank you.
Afternoon, colleagues.
Yes, we hear you. You can continue.
Oh, okay. Nonsikele Lontuli here from RFM Hospital, a nurse at Palliative Care Unit. I'll be presenting my case. My patient, who is a follow-up, 68 years old, a male with esophageal cancer. Problem: patients always want high doses of morphine, over 60 milligrams twice a day, in a day. He comes 2 weeks after refill, even when given a month's supply. Patient become aggressive and violent to family members whenever he has no morphine. Patient always complain of severe pain and feel like pain medication offered at the hospital is not enough. He is suspected of having other external supply of morphine. He has tracheostomy tube on that makes the patient not to speak properly, not yet willing to see a psychologist. Chief complaint: patient complained of severe pain on neck, pain score 10/10. Significant medical surgical history. Patient is a known hypertensive patient with peptic ulcer disease, patient on treatment. He started pain medication, morphine, 2003. He reports to be diagnosed with esophageal cancer in South Africa 19 years ago. He has done tracheostomy in South Africa, which is monitored by a private doctor in the country. He was using morphine injectable since 2003 until stopped 2018 and started taking it orally. He refills his antihypertensives, peptic ulcer disease, and pain medication monthly at RFM Palliative Care. Relevant past medications: morphine 15 milligrams IM BD. Current medications: morphine 30 milligrams POBD, bisacodyl 10 milligrams POOD, enalapril 20 milligrams orally 2 times a day, atenolol 15 milligrams orally once daily, nifedipine 20 milligrams orally 2 times a day, paracetamol 1 gram orally 3 times a day, omeprazole 20 milligrams orally 2 times a day. Please continue. Social history and pertinent family history. Work status: client is active and ambulating. Occupation is a pensioner. Education: he finished high school. Socioeconomic class: middle class. He is married. He's a non-smoker and non-alcoholic. Relevant health condition in the close family members, none. Advanced directives, not yet done, not yet discussed with the patient. Review of systems, vital signs, temperature 37.5 degrees Celsius, BP 149/87 millimeters of mercury, pulse 86 beats per minute, respirations 18 breaths per minute, SpO2 it's 100%. Pain score ranges from 8 to 10. ECOG functionality score, it's 0. Symptoms, patient reports pain, he is not dyspneic, there is anxiety, has agitation, depression, 0, drowsiness, there is none, nausea and vomiting, none, anorexia, none, constipation, it's mild, dry mouth, none, poor mobility, none. Focus investigations. Patient did an HIV test, it was found to be non-reactive. Further plan. Patient might have psychological or social pain. He was referred to see a psychologist, but patient is not yet willing to resume his counseling sessions. In an MDT meeting, it was also agreed on doing a home visit to assess the environment where the clients stay. Thank you.
Thank you so much, thank you so much for presenting such a wonderful case. I think we can all have a picture of what is happening with this patient. Indeed, it's a very serious situation the patient is going. A man 60 years old, 68 years old, esophageal cancer, and always in need of morphine, with tracheostomy, unable to express yourself verbally. You know, I would say those are the things the patient always complains of pain if it's to the state of being violent when the morphine is not there. What comments or questions we can have for doing this so they can manage better? They are saying they are planning for an MTD or family follow-up. What can we advise? What can we ask Judy? I think she can appreciate your input, colleagues, and even your comments, and even to answer any questions you may want to know about the patient. You may raise your hand or you may write on the chat your question, your suggestion, or whatever we can have. Let's manage the patient together. Let's support them to do better for our client. Maybe why the colleagues are still thinking of what they can ask or share. Maybe do you have any information on where the patient has been diagnosed and what treatment has been provided up to this far, as in terms of curative ones, or else in the stage of the cancer?
Okay. The history the patient is presenting with is not yet suggestive of being a cancer, because you can see by the years the client has lived. It's more than 18 years. It's 19 years, yes. and the doctors are still trying to make a follow-up on the private doctor that is monitoring the tracheostomy tube that the patient has. That's why it's confusing that the patients always want high doses of morphine, but the patient looks stable. There is no, he is not deteriorating. But we were told that he has esophageal cancer.
Okay, thank you. Meaning there's no documentation or results available to confirm the esophageal cancer.
Yeah, because the client was firstly managed at the ER. It was where he was given the morphine BD, the injectables, until palliative care department was opened 2017, if I'm not mistaken. He started the injectables 2003, and then they introduced palliative care at RFM to 2017. That's where then they started to stop him from using the injectables. It was also hard to do that, but fortunately, they were able to talk to him and stop the injectables. And he started to use the oral morphine.
Okay, thank you. I don't know, colleagues. We may ask anything from Julie or suggest anything. This is the case they are presenting. Let's ask or respond to how best they can deal with this case. Anyone with something to add or ask to the concerning this case? This is the client that we have today with any information. So, how is the patient taking the PO with the esophageal care? Are these the tablets or is the liquid morphine?
It's the tablets.
Okay. So he's taking them like via mouth or
Can you repeat the question?
Is he taking it like the tablet through the mouth or something else?
He is taking it oral.
So we can suggest what you think can be done and how best this patient can be managed. Or any question you feel like we don't have. Anyone with a question or suggestion? I'm surprised that some people are talking behind their parents. Some are saying it's a difficult client. So, has the patient ever stated why he is not willing to see the psychologist?
Not yet. For now, okay. For now, I was thinking that the patient is not okay because some healthcare workers, I may not state, would see who exactly. They suspect that the patient might be addicted to morphine now, but he is not accepting it. That's why he's running away from seeing the psychologist.
Yeah, I get it. The challenge is just that there is no, I don't know if doctors have ever thought of taking an X-ray or whatever to whatever examination that has to be done to confirm that this patient has got cancer. Because I've heard that he came through the ER, then they do the refill. But I've not heard that one. The doctor, how did he or she end up prescribing a morphine without a guarantee of the diagnosis behind? I understand that nationally you find that even if for refills, the patient will send the relative, but the initial prescription has to go through the doctor because he has to do some confirmation really deep. The patient is suffering from a certain life-limiting or threatening condition and really experiencing pain under cross-examination and assessment. So then it leaves me with the question that if they, as a palliative care unit, we are still also querying the issue. This patient is addicted. How will he be addicted if really is also PG? That's why I'm just confused. Then I was asking if are there any medical record that can confirm that there is a progressive illness behind? Because having cancer doesn't mean you die in 2 days. It doesn't mean that. That's why we cannot expect the patient to die quicker. It depends on the multiplication of the cancerous cells of the body and how speedily they are. So we cannot tell. You may find that the patient is finding some certain support at a side, then it can live long. But then from 2003 to now, but nobody is clean, no follow-up examination done to see if is the cancer improving or worsening, and then I'm like worried. What is happening here? The first one who initiated the opioid, was it based on a cancer or was based on something I had been lost? But I was asking if you have any document that can help you to understand the status quo of the cancer that is being. I don't know. I think my colleagues can say in such a situation. But I guess the family assessment, have you ever met the family member? Because those are other people that can also help you in the issue of the confirmation of a cancer behind. What did the family members say concerning the diagnosis themselves?
Okay, we have seen the wife of the client, and he also reports that the client has cancer. He was diagnosed in South Africa. I think at RFM, they came with papers written that client has esophageal cancer. Then now, after some many years, then the doctors are now realizing that this condition, it might not be cancer. How come it is not progressing? It is not advancing. There are some complications there and there.
So are they considering any further investigation of the carcinoma reporting? Like taking either samples for laboratory examination to confirm the cancer so that then if it's not, then we can find out. Maybe they initiated the morphine when they put it in the tracheostomy. Because maybe it was severe pain for us, I don't know.
Okay, one time our doctors from palliative care referred the client for surgical review, but the surgeon but the surgeon felt like they must have history from the doctor that is monitoring the tracheostomy too. Unfortunately, we couldn't get rid of him. There were some complications there and there. Hmm.
I don't know, do you have anything to say? It's like your case of everybody's confused. My comment has a hand to say.
Thank you so much, Tim. Thank you for the presentation, Ziggy. And it sounds a very complicated case. My question is just to ask you, Uti, if this patient is being monitored by a private doctor in country, can RFM be aggressive in getting to that doctor? Because I don't think it's somebody who's not reachable, because that is where we can really get another breakthrough while you are trying to confirm. My other opinion would be, we have oncologists in the country, in the Mbabane Government Hospital. Has it been considered that this patient be referred for further investigation by the oncologist while RFM is trying to confirm the diagnosis? Because if it is cancer, then I think the oncologist would have a better opinion on how to get to the bottom of this issue. Those are my thoughts. Thank you.
Thank you so much. I hope you have received the suggestion or comment to find a way out of this.
Okay, I will tell the doctors.
Another thing I will say that the total psychiatric history has also to be taken into consideration. There might be a possibility that initially it was something else, but then healing has happened, but then because of the addiction, because they also open receptors are no longer being opened, but now I'm finding pleasure in it. We continually looking for it to be there. But before we can decide that this one is addiction, we have to be sure of the pathology behind. We have to be sure of the reason of the first prescription itself. It's a pity that when you're looking for the doctor, you couldn't find. So you may never know whether it was the bogus doctor in the forest. So I think we need to follow up in this case because we have a lot of suspicions, and you need to also do the total assessment. And I would suggest that patient could also be linked to a psychiatric specialist who can also do some mental evaluation and assessment, and even the family assessment, and even explaining to them how dangerous it is to take morphine if it's not for the indicated. But the reality is, let's go back and trace where the patient came from and find out what is happening. The one who is monitoring the tracheostomy knows very well. And I guess another thing you can do is that when the patient comes for the fee, request the letter from the one who's monitoring the tracheostomy that you are requesting for a prescription letter from the one who's monitoring the tracheostomy. So that you can also be able to track who is really monitoring the tracheostomy, and then you are able to get contact with them. And then the oncologist also can have. We do have Manzini Hospital, they have an oncology. I thought they would be commenting here and saying what can be done, what we can do to save the life of the patient who is undergoing such. If anyone wants to add, then maybe we can look around wrapping up our session. Or is there anything you want to ask from our colleagues where you may need them to assist or advise you concerning the case? I think they are available also. You can ask.
Hi, Tim.
Yeah.
Ntuli, we understand you have a department for social workers at RFM. I think you can also engage them if you haven't, to speed up the process in finding facts on this patient so that he is assisted accordingly and the team is at peace, because now it raised a lot of suspicions. Thank you.
I hope you have got the suggestion.
Yes.
Do you have anything else to ask from the team?
Nothing.
Thank you so much for presenting such a case to us today. And we hope such suggestions will help you. Such cases, they are rare, but they do happen. And if we are not going to intervene as quick as possible, it will then contribute to the management of the legit and the patient who might need the morphine in the future, because they will then end up saying painting RFM is giving people to morphine who really don't deserve. So I think now that you have this suspicion in an opioid case, let's quickly intervene so that it doesn't spread across other healthcare professionals who have the notion that addiction, and pain management. If it's correctly prescribed to the right patient and the right dose, then it doesn't hurt. But if then such patient may present, and when they are not sure what they are presenting is all about, and then if we are not sure of something, we need to investigate about it and find it. If not, there's other patient to help us get that. And if we are suspecting such, it must be investigated. The director has also encouraged that getting social workers to speed up the process. If you need to travel to where the patient is, the facility, let's go to it, trace and find out. We may know about such a patient and how is the patient coping, and the reason they are not refilling the morphine for the patient and referring it out, so that we may understand all what is happening. We are a team and we are working together. And on that issue, let's not forget not to hate the patient. Let's find the team together and find the reason why he needs to attach to a psychologist, because I don't think he has already stated the reason, and ask him so that we can get a clear picture. Why is he not willing to do that? Maybe he will state something that he will be able to trace the cause and find out if he is that. On our chat, we have shared our feedback link for today. So we request that everyone who attended today will click that link before exiting today, and then you take the 2 minutes time to share your feedback with us concerning today's session. Our next session will be on the 21st of September, and we will be looking at comprehensive assessment. So we'll be starting on assessment, how to assess for pain. So we'll be starting there. So on the 21st of September, we'll be looking at assessment. Today we're introducing the concept. Then in the session, we'll be looking at pain assessment. We'll be starting there. And then we'll also unpack that service in pieces so that all of us can grab the skill of assessing the pain. And then if you will need today's session, it will be available in our YouTube channel, Eswatini Hospice at Home. You can access it there, or you can contact me for any materials you may need. They will be available for you at any time. So we kindly request all of you to click on the link there for feedback purposes. Thank you so much for participating in this session. May we request that in our next session, kindly invite others. Our registration link is free and shareable. Invite other healthcare professionals. Tomorrow is me, today is our patient. Tomorrow is you, today is our patient. Tomorrow is our relative, they will fall in the hands of the untrained health professionals. So let's share the information so that all of us, we can learn together and share the practices together, like we've done to be with them. I hope Nazareth will do better for this client, and we are happy, we will be happy to hear in the future what happens to this client if you will remember to share with us one day what happened with the patient, we can all be motivated what the patient helped concerning the morphine. Because today we cannot say it's addiction until we can confirm it. Thank you so much. Have a good and nice day.
Thank you.
Bye. Remember to click the link before you exit. Bye-bye. Thank you.